Hello everyone and welcome to another video of our internal medicine board review questions. These questions are in general nephrology. This is part 6. Here's my book. You can find it on Amazon. Please follow the link below. You can also find links to the other videos, other board review videos in the description below. So let's get started. Question number 1. We have a 51-year-old man presents to the renal clinic for a routine follow-up. He has stage 4 chronic kidney disease secondary to diabetic nephropathy, and he is complaining of mild fatigue. Laboratory evaluation reveals hemoglobin 10.9 gram per deciliter, so a little bit low. Creatinine elevated at 3.7 milligram per deciliter. BUN also elevated at 52. Estimated GFR using the CKD-EPI equation is 19 milliliter per minute per 1.73 meters squared. Potassium and bicarb are both essentially normal. Medical therapy has been optimized during previous visits. So now, what do we do with this patient who's complaining of mild fatigue? He has stage 4 chronic kidney disease due to diabetic nephropathy. A. Insertion of peritoneal dialysis catheter. B. Insertion of a tunneled hemodialysis catheter followed immediately by hemodialysis. C. Starting erythropoietin injections for anemia management. Or D. Referral for kidney transplant evaluation. The answer will be on the next slide, so you can pause here if you wish. And the correct answer is D. Kidney transplant evaluation. So why is that? This patient has very mild, if any, uremic symptoms. Starting erythropoietin injections, this is option C, is premature. Hemoglobin is slightly low. Most people would wait until hemoglobin is between 9 to 10 to initiate that. So this is not the best answer. Initiation of dialysis, whether via peritoneal dialysis catheter or a tunneled hemodialysis catheter, is also not a good answer because the patient does not need dialysis based on physical exam symptoms or laboratory values. So there's no indication to initiate hemodialysis. Now, what this patient needs is kidney transplant evaluation. Now, another good option would have been, if he wants hemodialysis, is to refer for vascular access. So this is based on his eGFR below 20, so this is a good time to refer for vascular access if he wants hemodialysis. And for kidney transplant evaluation, patients can be listed on a transplant list if eGFR is below 20. Now, what you really need to know is, for a patient like this one who has diabetic nephropathy, who's relatively young, longevity on kidney transplant is much, much better than hemodialysis. So what is the best treatment? What is the best renal replacement therapy? It's always kidney transplant, unless there's a contraindication. So if you have someone with really advanced aged, someone with multiple comorbidities, then you're going to be stuck with the hemodialysis or peritoneal dialysis. Otherwise, the correct answer is always going to be kidney transplant evaluation, unless there is a contraindication. Question number 2. A 72-year-old man is referred to the renal clinic for evaluation of hypercalcemia. His main complaint is low back pain. His medications include over-the-counter ibuprofen. He's been taking 200 milligrams 4 times a day, lisinopril 20 milligrams a day for high blood pressure, and pantoprazole 40 milligrams daily for gastroesophageal reflux disease. Laboratory evaluation revealed a hemoglobin of 9.4 gram per deciliter. Calcium was elevated at 11.1 milligram per deciliter, and ionized calcium was also elevated, so this is verified. Creatinine is elevated 1.9 milligram per deciliter. Urinalysis shows 1 plus protein, 2 red blood cells, and 3 white blood cells per high power field. Now, urine protein creatinine ratio was very high, 3,125 milligram of protein per gram creatinine. So, ibuprofen was discontinued. What is the next best step in management? Is it A, proceed with a bone marrow biopsy? Is it B, discontinue lisinopril and pantoprazole and repeat labs in 2 weeks, see if they will get better? C, check 125 dihydroxyvitamin D level. This is further evaluation for hypercalcemia. Or is it D, serum and urine protein immunofixation? So you can pause the slide here for a second and the answer will be on the next screen. The correct answer is D, serum and urine protein immunofixation. Here really we are looking for a diagnosis of multiple myeloma. You have someone who is older with anemia, hypercalcemia, kidney impairment, and then proteinuria, not just proteinuria on the dipstick. There's only one protein, 1 plus protein, because this checks for albumin, while you have a lot of light chains, so this is why the urine protein creatinine ratio is very elevated. So it really cannot get easier than this. This question is spelling multiple myeloma, hypercalcemia, plus many other things. So a bone marrow biopsy is not a bad idea, and you will have to do that soon, but first you have to prove the diagnosis. So answer A is not the best answer. It is coming. The same if you would say a kidney biopsy. The correct answer is D, serum and urine protein immunofixation, because you have to prove the diagnosis biochemically first. And then you can do your bone marrow biopsy, you can do a kidney biopsy, possibly you can do bone survey, etc. Discontinuation of lisinopril and pantoprazole, well, creatinine may improve after 2 weeks, but you're not really making the diagnosis. Now, checking 1,25-dihydroxy-D, this is elevated in diagnoses like tuberculosis, sarcoidosis, borreliosis. They all cause hypercalcemia, but the story really doesn't suggest any of these diagnoses. So by far, the correct answer is D, serum and urine protein immunofixation. Question number 3. So this question is a little bit difficult. It requires some thinking. Okay. A 76-year-old woman with severe depression presents to the emergency department with 1-week history of nausea, vomiting, confusion, and falls. Medications include aspirin, lisinopril, sertraline, and quetiapine. Physical examination is remarkable for tachypnea. Laboratory evaluation reveals a sodium of 143, potassium 3.3, chloride 101, and bicarbonate 21, all in mil equivalents per liters. Arterial blood gases, pH 7.58, PCO2 23, PO2 91. What is the acid-base disorder? Is it respiratory alkalosis? Is it respiratory alkalosis and metabolic alkalosis? Is it C, respiratory alkalosis, metabolic alkalosis, and high anion gap metabolic acidosis? Or is it D, respiratory alkalosis, metabolic alkalosis, and normal anion gap metabolic acidosis? So please pause the slide. You will have to pause it and do calculations, and the answer will be on the next screen. I hope that you got this one. The correct answer is C, complex acid-base disorder. So respiratory alkalosis, metabolic alkalosis, and high anion gap metabolic acidosis. So how can we reach this complex diagnosis? Well, you have to think like a professor. Now let's highlight the important areas, the clues in the stem of the question. So we have an elderly woman, a 76-year-old woman with severe depression. So that makes us think, okay, maybe overdose toxicity. She presents with 1-week history. So the symptoms are rather chronic, didn't happen just yesterday. Nausea, vomiting, confusion, and falls. Non-specific symptoms. Medications include aspirin. So could that be aspirin toxicity? The answer is yes. Lisinopril, one of the medications, sertraline and quetiapine, they go with severe depression. Physical exam goes with tachypnea, so this is another clue for aspirin toxicity. Then we look at the lab. Sodium is a little bit high. Well, she's been vomiting, so she's dehydrated. The same goes for the potassium, nothing surprising. Chloride 101, bicarb 21. And now we have to make a diagnosis based on the chemistries and the ABGs. Okay, this is how we do it. Now, let's look at the pH. pH is 7.58. What's this? This is alkalemia, okay? So we have alkalemia. Is it due to respiratory alkalosis or due to metabolic alkalosis or both? this is what we have to figure out. So we look at the pH, alkalemia, we look at the PCO2, it is low, not high. So we have respiratory alkalosis. So this is our first diagnosis. It's due to aspirin overdose. Now, if you remember correctly, aspirin overdose causes respiratory alkalosis and metabolic acidosis. Okay, in adults, you see more respiratory alkalosis. In children, you see more metabolic acidosis, and the metabolic acidosis is due to not just salicylate, it's mostly lactic acidosis. At any rate, so we have respiratory alkalosis. Why? We have a pH that is high and we have PCO2 that is low. That's easy, okay? And respiratory alkalosis is part of every answer, so you haven't achieved much by doing that. Now, the next step after we made the first diagnosis is to calculate the compensation for respiratory alkalosis. Is it chronic or is it acute? Because the compensation is different. It is chronic, it's more than 2 days, so we have here 1 week history. So the compensation, every time the PCO2 goes down by 10, bicarb should go down by 5. So the PCO2 went down from a normal of 40 to 23, so by about 20s or by about 2/10. This means the bicarb should go down by 5 and 5, by 10, but it didn't go by 20, it went down by 17. So the bicarb should go down, should drop by 9, and it's expected to be 15. But look, the actual bicarb is not 15, it is 21. So this means that the bicarb is higher than what it should be, which means that we have metabolic alkalosis, which is due to vomiting. So this is our second diagnosis, respiratory alkalosis and metabolic alkalosis. Then we calculate the anion gap. The anion gap is sodium minus chloride plus bicarb, and it's 21. Okay, when you have an anion gap of 21, you have metabolic acidosis. Okay, you're done. Okay, nothing else will give you that high anion gap. Okay, when we have metabolic acidosis, it can be high anion gap or normal anion gap. Well, I'm telling you, the anion gap is high. So you have a high anion gap metabolic acidosis due to salicylate toxicity from lactic acidosis and salicylate. Okay, here we have another clue for the presence of metabolic alkalosis, and it is the delta-delta. You can see here that the delta anion gap, the anion gap increased by 11. A normal anion gap of 10, we have here 21, so 21 minus 10 is 11. But the bicarb only went down by 3. Okay, so the change in bicarb is far less than the change in anion gap, and this is because the bicarb is up from metabolic alkalosis. Again, another clue for metabolic alkalosis. Therefore, the final diagnosis is a complex acid-base disorder, respiratory alkalosis, metabolic alkalosis, and high anion gap metabolic acidosis. I hope that you did as well as Professor Frank, and acid-base disorders cannot get more complicated than this. So this is as bad as it's gonna get. Question number 4. A 19-year-old man presents to the renal clinic for evaluation of gross hematuria that was noted a few hours after he participated in a 10K race. He has had 2 episodes of gross hematuria over the past year, shortly following the onset of an upper respiratory tract infection, so 3 episodes so far this year. All of these episodes resolved spontaneously. The patient has no complaints, so he's completely asymptomatic. His exam is unremarkable. Past medical history is also unremarkable. He does not take any medications, and family history is negative for renal disease. Laboratory evaluation, creatinine is normal, 0.7 milligram per deciliter. Urinalysis shows 1 plus protein, 7 RBCs per high power field, and 1 WBC per high power field. C3 and C4 complement levels are normal. Urine protein to creatinine ratio is 123 milligram per gram. Normal should be less than 30. Renal ultrasound is unremarkable, so there are no stones, no cysts, no tumors, no masses. What is the likely diagnosis? Is it A, lupus nephritis, B, C3 glomerulopathy, C, IgA nephropathy, or is it D, post-infectious glomerulonephritis? Please pause the slide, think about the different answer, and the correct answer will be on the next slide. And the correct answer is C, IgA nephropathy. Now, really, this condition is very consistent with IgA nephropathy. You have someone who gets painless, asymptomatic hematuria after intense physical activity or upper respiratory tract infection. So this is IgA nephropathy. You can get the same with Alport syndrome or thin glomerular basement membrane disease, but those conditions have usually family history. With Alport, you have hearing loss, and we don't have that in this question. More so, we don't even have those as an option. Lupus nephritis is more common in women, and I didn't give any of the manifestations of SLE. Complement is normal, so this is not a very likely diagnosis. Post-infectious GN is a possibility, but C3 and C4 can be low in many cases. So this scenario fits IgA nephropathy better. C3 glomerulopathy initially looks like post-infectious GN. You can only diagnose it on a kidney biopsy, and the scenario doesn't fit that diagnosis. You can see the picture of IgA nephropathy. This is from my review article on the subject. I'll provide a link in the description. The only way to make the diagnosis of IgA nephropathy is by doing a kidney biopsy, and you have to make the diagnosis on the immunofluorescence. As you can see, you have mesangial deposits of IgA. It lights up like that. And so the answer is C, IgA nephropathy. Question number 5. A 35-year-old woman presents to the renal clinic for an evaluation 3 months after a successful deceased donor kidney transplantation. Her end-stage renal disease was due to IgA nephropathy. Her immunosuppression regimen includes prednisone 10 mg a day, tacrolimus 3 mg twice a day, and mycophenolate mofetil MMF 1000 mg twice a day. Creatinine 0.9 mg per deciliter. She asks whether pregnancy is currently advisable 3 months after transplant. What is the best advice for this patient? A. Proceed with pregnancy if allograft function remains stable for 1 to 2 years from the time of transplant. So she has to wait another 1 to 2 years. B. Proceed with pregnancy after discontinuation of prednisone. You keep her on the tacrolimus and mycophenolate. C. Proceed with pregnancy after substituting cyclosporin for tacrolimus. So you stop tacrolimus and you put her on cyclosporin, then she can proceed with pregnancy. D. Proceed with pregnancy after substituting azathioprine for mycophenolate mofetil. So you stop the MMF and you put her on azathioprine. So which of these options is correct? So you can pause for a second, and the correct answer is A. Proceed with pregnancy if allograft function remains stable for 1 to 2 years from the time of transplant. So B, C, and D, really, they don't matter. You have to wait. If the creatinine is stable, there's no proteinuria, blood pressure is fine, you're not having episodes of acute rejection, and it's been 1 to 2 years, then you can proceed with pregnancy. Now, in that interval, contraception is strongly advisable. Now, that's the correct answer, A. We'll proceed to question number 6. So the same patient now waited for 24 months as you advised, and she returns to the clinic. Now she's on prednisone 5 mg, so the dose went down from 10 to 5. Tacrolimus 3 mg twice a day from 3 twice a day, so it's lower. And also the mycophenolate mofetil, the dose went down to 500 mg twice a day. Her creatinine is 1.1, so a little bit higher than 3 months post-transplant with 0.9. It's 1.1 milligram per deciliter, but stable. And now she asks whether pregnancy is advisable. So what is your best advice for this patient now? Is it A, advice against pregnancy because creatinine is over 1? B, proceed with pregnancy. The patient can proceed with pregnancy after discontinuation of prednisone. C, proceed with pregnancy after stopping tacrolimus and starting cyclosporin. Or is it D, proceed with pregnancy after substituting azathioprine for mycophenolate mofetil? So think about these different answers, and the correct answer is D. Proceed with pregnancy after substituting azathioprine for mycophenolate mofetil. So A is not correct. A creatinine of 1.1 is fine as long as the patient is stable, good blood pressure, no acute rejection episodes, etc. Discontinuation of prednisone may lead to acute rejection, so it's a horrible idea. Substituting cyclosporin for tacrolimus doesn't do anything. Tacrolimus is safe for pregnancy, so it's not the issue. The issue is mycophenolate mofetil. There is a black box warning. It says that females of childbearing potential should use contraception if they're on cell-safe mycophenolate mofetil. Why? Because you have risk of congenital malformations and pregnancy loss. Any physician who prescribes mycophenolate should enroll in REMS, which is risk evaluation and mitigation strategy. You have to complete online training so you know the risks involved. So what we do in these situations, you stop the mycophenolate, you put the patient on azathioprine, which is considered safe in pregnancy, and after a while, she can proceed with pregnancy. So the correct answer is D. Question number 7. A 36-year-old woman with a known history of essential hypertension presents for pre-pregnancy counseling. Her blood pressure has been well controlled with candesartan, which is an angiotensin receptor blocker, 32 milligrams daily, and hydrochlorothiazide, 25 milligrams daily. What is the next step in her blood pressure management? Is it A, no change in medications, B, discontinue candesartan, continue hydrochlorothiazide, and start nifedipine, C, discontinue both candesartan and hydrochlorothiazide and start lisinopril, or is it D, discontinue both candesartan and hydrochlorothiazide and start non-pharmacological measures for blood pressure management and observe? The answer will be on the next slide, and the correct answer is B, discontinue candesartan, continue hydrochlorothiazide, and start nifedipine. The point of this question, we all should know that angiotensin receptor blockers and ACE inhibitors are absolutely contraindicated in pregnancy. They should be preferably stopped before pregnancy, and in case pregnancy is detected, they should be discontinued immediately. So no angiotensin receptor blockers, no ACE inhibitors, and no spironolactone in case of pregnancy. So this is a black box warning. So we have to discontinue candesartan. Diuretics, the rule of diuretics, if the patient is already on a diuretic before pregnancy, they can continue with it after pregnancy. Or I should say during pregnancy. Now, of all the blood pressure medications we can use in pregnancy, nifedipine is very well known, very safe. So here what we need to do is B, you discontinue a medication, candesartan, but this will lead to elevation in blood pressure, and you don't want that. So you have to start nifedipine in its place, probably starting at 30 milligrams a day, and you continue the diuretic. If you don't change medications, answer A is wrong because you have to stop candesartan. C, discontinue both and start lisinopril doesn't solve the problem because you cannot use an ACE inhibitor in pregnancy, so C is wrong. Option D, discontinue both and start non-pharmacological measures. That's not enough. This patient is needing 2 medications to control her blood pressure. If you stop both and you just do non-pharmacological measures, which you should do anyway, her blood pressure is not going to be controlled. So the correct answer is B. Question number 8. We have a 53-year-old woman who presents with severe nausea and severe diarrhea due to food poisoning. Labs, sodium is low, 128, potassium 2.7, chloride 98, and bicarbonate 19, all in milliliter equivalents per liter. How would you manage her electrolyte disorder? A, replace potassium, then start an isotonic sodium bicarbonate solution, meaning 150 milliliter equivalents of sodium bicarbonate in 1 liter of D5. B, start lactated Ringer solution. C, start 0.9 normal saline. Or D, start 0.45 normal saline with 40 milliliter equivalents of KCl. and think about these different answers, and the correct answer is A. Replace potassium, then replace bicarb. So this patient has severe diarrhea. She has non-anion gap metabolic acidosis, but she is hypokalemic. If you start by replacing bicarbonate, which you should replace, you are going to drive potassium intracellularly and make the hypokalemia worse. So potassium takes priority. Whether you have hypokalemia or hyperkalemia, you should address potassium first because of its effect on the myocardium. So here we are going to replace potassium. It is below 3, so you have to replace intravenously. You can do both, oral and intravenous, but you have to replace intravenously. After you've given some potassium, maybe 40 milliequivalents, intravenously, maybe plus 40 PO. This is going to take you about 4 hours. Then you can replace sodium bicarbonate. You need to replace it because it was lost, and this will help you with volume. This will help the sodium, and this will help the bicarbonate. So potassium first, bicarb second. Lactated ringer is not a terrible answer. It's not the best answer though. It has lactate, so it will give you bicarb. Has some potassium, but not nearly enough. So it's not the best answer. Normal saline is not a good answer. Why? Because it doesn't give you potassium and it doesn't give you bicarb. So yes, if you replace volume, but not with the correct solutions. D, you will address the potassium because you're giving half normal saline plus potassium, but this solution is a little bit hypotonic, so you could make the hyponatremia worse, and you're not addressing the low bicarbonate. You're not addressing the non-anion gap metabolic acidosis. So the correct answer is A. Question 9. A 23-year-old man with a known history of major depression presents to the emergency department after a suicide attempt. The patient ingested an unknown amount of an antifreeze. Laboratory evaluation revealed pH 7.21, serum osmolar gap 35, serum bicarbonate 10. Creatinine is elevated at 1.8. Urinalysis shows crystals as on the screen. On exam, the patient was lethargic. What is the next best step in his management? A. Order methanol and ethylene glycol levels. Once you confirm the diagnosis, proceed with intravenous famotidine. B. Intravenous famotidine, and if there's no improvement after 4 hours, proceed with hemodialysis. C. Intravenous famotidine and emergency hemodialysis. D. Intravenous famotidine and peritoneal dialysis. Think about these different options, and the correct answer is C. Intravenous famotidine and emergency hemodialysis. So this case, clearly this patient has ethylene glycol toxicity. He ingested antifreeze. We have calcium oxalate crystals in the urine, and he has a big osmolar gap. His creatinine is elevated. His pH is low, bicarb is low, so we know that he has metabolic acidosis. The patient is lethargic. So here you have a true emergency. So yes, you are going to start the patient on intravenous bicarbonate drip. Yes, you are probably going to give B1 and B6. But more importantly, you are going to start famotidine intravenously right away. And you are going to prepare for emergency hemodialysis. This will save his life and his kidneys. So the answer is C. Now, option 1 is terrible. It can take several hours to get the level, and it's not going to change anything. We're very sure of the diagnosis. So option A is unacceptable. Option B is not enough. So because the patient is lethargic, he is in acute kidney injury, you have to do both. So famotidine is not enough in and of itself. Option D, peritoneal dialysis, would be very slow for removing ethylene glycol, so very ineffective. Even if the patient was a peritoneal dialysis patient, I would still put a catheter in and do hemodialysis. So clearly the correct answer is C. Last question for this video. A 55-year-old woman with a new diagnosis of type 2 diabetes mellitus was started on canagliflozin 300 milligrams daily. 1 week later, she presented to the emergency department with nausea, fatigue, and abdominal pain. Laboratory evaluation revealed sodium 142, potassium 5.1, chloride 103, bicarbonate 20, and ion gap elevated at 19. Blood glucose 160, ABGs, pH 7.39, PaCO2 of 34. What is the next best step in her management? A. Check lactic acid and procalcitonin. If both are elevated, start intravenous antibiotics. B. Start intravenous sodium bicarbonate drip. C. Check beta-hydroxybutyrate level. And if elevated, start intravenous insulin per DKA protocol, diabetic ketoacidosis protocol. Or D. Check methanol and ethylene glycol levels. So pause the video for a second, think about different options, and the correct answer is... So the correct answer here is C. Check beta-hydroxybutyrate, and if elevated, start intravenous insulin per DKA, diabetic ketoacidosis protocol. So here we have a patient with nausea, fatigue, and abdominal pain after starting an SGLT2 inhibitor, canagliflozin, and she presents with metabolic acidosis. We have high anion gap. This is the clue. The pH is normal. But the clue to the metabolic acidosis is the low bicarbonate and the high anion gap. By the way, this case is real, so these numbers are what actually happened in this case. At any rate, we have to diagnose first that the patient has metabolic acidosis, second, determine why she's acidotic, and third, how we're going to manage it. Now, option A, lactic acid and procalcitonin, she doesn't seem septic. Okay, I didn't give you anything to suggest sepsis. I didn't even give you a CBC. There's no fever, nothing to suggest infection. Of course, it's not a bad idea to check lactic acid, but this is not going to go much further. Giving intravenous sodium bicarbonate, yeah, you're replacing bicarbonate, but you didn't make a diagnosis and you're not treating the underlying cause. D, this is a little bit too far. There's nothing to suggest poisoning, methanol, ethylene glycol. The stem really doesn't point us in that direction. You could check an osmolar gap, a serum osmolar gap. If elevated, you can do that, but it's not the best step. So what's actually is going on here? So this patient pH is in the normal range, but her bicarb is low and her anion gap is high, so we have metabolic acidosis, high anion gap metabolic acidosis. The diagnosis is euglycemic diabetic ketoacidosis. This has been described in patients taking sodium glucose cotransporter 2 SGLT2 inhibitors, such as canagliflozin. So we have canagliflozin, dapagliflozin, empagliflozin, ertugliflozin, and others. Now, the patient has an anion gap metabolic acidosis due to euglycemic DKA. So the glucose will be either a little bit elevated or even completely normal. Why does it happen? Because of change in metabolism in the liver by these medications. They shift the metabolic pathways towards acidosis, towards ketoacidosis. Now, the diagnosis was confirmed by measuring a beta-hydroxybutyrate, and in this case, it was elevated 4 millimole per liter. The patient was started on DKA protocol, received intravenous insulin with good results. It just so happened that 2 days ago, I had another case with empagliflozin. It was a mystery metabolic acidosis. The level was higher, the beta-hydroxybutyrate was 5.6, and the treatment is the same. You do the DKA protocol. I think this is the 4th case I see with the euglycemic diabetic ketoacidosis from the SGLT2 inhibitors. The reason I put this question, these medications are great. They have so many indications, and as we use them more, we are going to see these rare complications more. So I will end here. Please support the channel. Check out my book on Amazon. Like the videos. Share the video. See you with the next installation of this series.